surgeon from Kenya, and I'll talk about tetralogy of Fallot, and I'm going to give it a slightly different approach in line with the theme. I'm going to set our experience in line with the development of a cardiac surgery unit so that you can see how tetralogy is juxtaposed to development of a unit. I hope you don't mind. Next slide, please. Right, so the background is it's a 10-year experience. The unit started at the end of 2013. So we only did one case that year. So we're really only considering years 2014 up to 2023. We've stopped operating this year. And the setting is Gertrude's Children's Hospital, which is a children's hospital in Nairobi, Kenya. It's a private institution, and we'll just see what this looks like. So next slide, please. Thank you. So we did a total of 187 operations. These are not tetralogy of Fallot, sorry. This is the total number of cases that the unit has done in the last 10 years. So this gives you the kind of situation you're having in a developing country that's starting a unit without help from abroad. And 64% of cases were on bypass and 36% non-bypass. Next slide, please. And this just gives you how we progressed. Like I say, 2013, really, we didn't do many cases, only one bypass case, really. But what I'd like you to see is that big gap in the middle. That was when COVID hit, more or less, coming into COVID, particularly 2019, 2020. But you can see that there is a slow progression. We are now back to pre-COVID kind of load, but it's definitely hard going. This is all, you can see the blue represents the total cardiac cases in a year. So you can see in a unit where we've reached, we're roughly at 35 cases a year. This is, and you can see the pump, on pump versus off pump. Just to give you a context of what we are achieving, we're just trying to make things happen. We're trying to move forward. Next slide, please. So this is really now the tetralogy of Fallot experience. It's 22 patients over that period. So you can see it's not a lot of patients, but we just want to show you what we've been able to do. 82% of them were total correction, and we were still had a few cases where we did shunts. Next slide. Next slide, please. Yeah, thank you. So this gives you an idea of the progress from year 1 of the program to year 10. You can see that we didn't start doing tetralogies, and it was pretty hard deciding not to do, wisdom from, can I say, more experienced colleagues said, when you're starting a unit, don't start with relatively more complex cases, even though we know tetralogies can range from being relatively straightforward to more complex. So we really don't start dealing with tetralogies till our 2nd year of running. And even then, that's when we did most of the shunts. And it's only more recently that we've been doing the actual total corrections. You can see in our busiest year, we only did 6 in a year. But that's the reality on the ground. As we speak, we're the only pediatric unit in the country that can mount an open heart at will without waiting and getting everybody, trying to get people coming in from abroad, trying to get people from different places. We're able to do it. Next slide. Next slide, please. So this just gives you an idea of our outcomes in terms of operative mortality. And so we were running at a 5% operative mortality until the last case we did, which was just under a week ago, which unfortunately we lost that patient. And that, because our numbers are small, that shot up our mortality to about 11%. But you can see that doing the BT shunts, although it's a small number of patients, it's a battle we've been having with our cardiology colleagues. Through the years, they've wanted us to do shunts instead of total corrections, and I tell them, look, a well-done total correction is probably less of a mortality risk than a BT shunt. So next slide. So these are the details of the intraoperative technique. 77% of our patients, we don't do a transannular patch. We've only done a transannular patch in about 6%, but we definitely do an RVOT patch. Early on in my experience, I would try to resect muscle and everything, and I had seen more experienced surgeons doing the same, but we still got bad gradients after. And really what I've seen is you really have to look at that RVOT and that anterior deviation of the septum. You can resect all the muscle you want, but if it's really anterior deviated, you just won't get a good outflow if you don't put in a patch. So I think that's what's reflected there. Next slide, please. This gives you an idea of, before I talk about this, I just want to mention how we decide whether we're putting in a transannular patch or not is based on two studies. Well, it's really just one study we did in New Zealand on their data. And basically what we looked at was, if you did nothing in terms of we looked at in all their database, we isolated a subset of patients who did not have a transannular patch and did not have subannular RVOT obstruction post-op, and neither did they have any obstruction distal to the pulmonary annulus. So out of maybe 400 patients, we only, the group that fitted that subset was about maybe 45 to 50 patients, and we looked at them, and we looked at the gradients across the pulmonary annulus based on size of Z-score, and we used the best available Z-score data, and we found that once your Z-score is smaller than minus 1.3, you have a 25% chance of having a gradient above 30 across that. And so, we decided that basically your heart, or a child's heart, it needs normal sized structures for it to work well. That's really what we picked from that. So if we have a transannular patch, if we have an annulus that's smaller than -2, we will definitely say you need to think about putting a transannular patch. Certainly, if it's smaller than -3, you definitely get a transannular patch. So that's one key thing. The next key thing, which I hadn't put on a slide, which I want to mention, and the previous speaker talked about it. Pre-op, all our patients get a CT angio to look for MAPCAS, and big MAPCAS need attention. We find that if you have big MAPCAS and you're doing your repair, you'll have problems with ventilation. You'll have thick bloody sputum coming up the tracheal tube quite a lot. And there's a paper, I hadn't put it here, but I would have liked us. It's what we use to make our decisions. There is a score we use. It's where you add up on CT angio, you add up the radii squared of all your MAPCAS and divide it by the weight of your patient. And it's a study based on 200 patients. And if that score is less than 1, you really don't need to do anything about those MAPCAS. If it's more than 2, then you need to actually deal with those MAPCAS. And our previous speaker spoke about how you can do it, but you need to deal with them. And if you're in between, like the last patient we talked about that we did and unfortunately passed away, you're doing 1.4, 1.5, 1.6, you may need to do something about those MAPCAs. And we had a real debate as to whether to go back on go back from ICU to theater, because we didn't have a cath lab support in that setting. So it's very important, I think, to assess the MAPCAs. Now, patient details. Patients, the ones who did total correction, the mean age was about 55 months. And for the guys who we did shunts on, it's only just less than 5 months. And I've put this slide here to show that I think within the fraternity, we found resistance. I think our colleagues, and I don't mean to be unfair, but it's something I have to say. I think our colleagues on the cardiology side are a bit hesitant to offer patients for repair. They'd rather we do a shunt, and this might be part of what we are seeing with this age differential. Next slide, please.
Dr. Mark, can you please move your camera to the upside, please? Actually, your face is cut in the camera. Sorry for the interruption. Yes, we can see you. But when you are close, then...
Next slide. Next slide, please.
Yes, she's trying.
Yeah. Thank you so much. So my final words would be that on a recent study done at our public hospital, we found that the median age of when congenital heart disease was suspected in patients from various parts of our country who converged on our hospital was 9 weeks. And this has improved over the years. And the median age when it was diagnosed was 13 weeks. And the median age when surgery was done was 25 weeks. And 50% of the patients died while they were awaiting surgery. And, when I tie this in with the previous slide, my message is, I think there is a delay. I don't think the patients are getting to places where they can be helped locally fast enough. And I think that's something I hope in this conference we will look at and discuss, and it will be interesting to hear what other colleagues have found. So that's our experience. And most of this unit is run essentially by local surgeon, local cardiologists, everybody's local. More recently, maybe in the last couple of years, we've had a collaboration with an Egyptian team. And the idea is that they come in to do things we clearly are not going to do at that point. Maybe we don't have RVOT conduits, and they'll bring it in and they'll put the patient. Not that we can't technically do, but that we may not have the material. So the final take-home message, I put that slide up once more. I forgot that was there. I just want to show you something. Put that slide up, then we're done. Yes, thank you. So in that group of patients who are seen at our main referral hospital and were being followed up, I want you to see that there were 3 times, 21% of them were advised to have surgery abroad compared to the 7% who were advised to have surgery locally. And this is for cases which can actually be done locally. And this is the battle that we're having to fight, at least for us. At least for me in Kenya, this is what I'm having to fight. I don't want to stop a patient who needs surgery abroad and I can't do it. And certainly patients should have a choice where they want to go. But I do feel that we should be promoting ability of local surgical teams if the results are good. So thank you very much.